And we're pleased to have Jenny Lim give the first talk. It's on outcomes of combined Phaco pars plana vitrectomy versus sequential surgery. Thanks, Jenny.
Thank you, John and Ehab. Good afternoon. It's my pleasure to present to you the studies comparing combined Phacovitrectomy with sequential surgery. These are my financial disclosures, the relevant one of which is Alcon. The combination of cataract extraction with vitrectomy was first described by Macular, and the combination of Phacovitrectomy was described by Cleesby and originally published by Coleman in 1975. Indications for combined Phacovitrectomy include a retinal disease requiring vitrectomy with concomitant visually significant cataract, retinal disease requiring vitrectomy with a baseline cataract, as this is known to progress faster to significance than a clear lens. In addition, retinal surgery requiring the use of intraocular gas, which accelerates cataract formation, is another indication. Benefits of combined Phacovitrectomy include intraoperative improved visualization of the posterior segment, as well as the opportunity for a more complete vitreous-based shaving. Postoperative benefits include a finer, faster visual acuity achievement, obviation of the need for a second surgery and need for additional procedures, including a YAG capsulotomy, and also improvement of quality of life. Economic benefits include a 17 to 20% savings per procedure, as published this year. Blankenship in 1980 performed a randomized study of 50 eyes that were diabetic requiring vitrectomy with clear lenses, and he randomized these patients into vitrectomy or vitrectomy with lensectomy. At 6 months, there was no visual acuity difference between the two groups. However, the aphakic group had higher rates of elevated IOP, peripheral iris rubiosis, and neovascular glaucoma, and this urged some caution. However, since then, there's been improved instrumentation and techniques, and now the combined surgery preferred is vitrectomy with phacoemulsification and insertion of a posterior chamber lens implant. So let's look at the evidence. First of all, let's look at Phacovitrectomy versus vitrectomy alone for epiretinal membranes. In a study by you of 81 patients, 41 of whom underwent combined Phacovitrectomy and 40 who underwent vitrectomy alone, there was no difference in best-corrected visual acuity at 6 or 12 months post-operatively in either group, and central subfield thickness or complication rates between the two groups. In a larger study by Dugas of 174 eyes, in which 109 underwent combined Phacovitrectomy and 65 underwent sequential surgery, with Phaco being done at a mean of 7.5 months, there was an improvement in visual acuity for both groups at 12 months compared to baseline. However, the visual acuity was significantly different at 6 months only for the group that underwent combined Phacovitrectomy when compared to baseline, thus suggesting a quicker recovery of visual acuity best corrected. In a smaller series in our group, in which is ongoing, we have looked at 35 months follow-up and again also found a faster improvement to final visual acuity and sustained improvement in the combined group as opposed to the sequential group. Let's turn now to proliferative diabetic retinopathy. In a retrospective study of 223 eyes, Leahy showed the possibility of using Phacovitrectomy for eyes undergoing vitrectomy for complications of diabetes, including vitreous hemorrhage, traction retinal detachment, or macular traction. Visual acuity was significantly improved by 4.3 Snellen lines with a mean follow-up of 10 months. In a retrospective study of 251 eyes by Silva, Phacovitrectomy in 129 eyes was compared to sequential vitrectomy in 122 eyes. Again, similar visual acuity increases were seen over 4 years, and the rates of diabetic retinopathy progression, vitreous hemorrhage, or retinal detachment did not differ between the two groups. There was, however, a slight trend towards more neovascular glaucoma in the combined group. The rates of cataract formation were quite high in the groups that underwent vitrectomy alone at 64%, 39% of which required cataract extraction with a lens implant. A meta-analysis has also been done looking at combined surgery versus sequential surgery in diabetic eyes, and in this study, again, the rates of cataract formation were quite high in the eyes that only underwent sequential surgery. So the conclusion was that although the visual acuity did not differ between the two groups, vitrectomy combined with cataract surgery achieved good outcomes without a substantial risk to visual acuity or most complications sooner with the combined procedure. There was a higher rate of iris neovascularization, however, in the combined group. The authors, however, concluded that given the high rates of cataract progression, combined surgery may be the more appropriate treatment for patients with diabetes and a coexistent visually significant cataract. Let's turn now to phacovitrectomy for macular diseases, including VMT, macular hole, and epiretinal membrane. In a retrospective review of 565 eyes by Sevastano, phacovitrectomy in 348 was compared to sequential vitrectomy in 217 eyes. Again, there was no difference in visual acuity outcome or complications or CME between the two groups. Let's turn now to complex retinal detachment repair. In a retrospective study of 30 eyes by Moon, again, phacovitrectomy was shown to be feasible with good visual acuity and anatomic outcomes. However, in this group, 10% were noted to develop an epiretinal membrane. Let's look now at a study by CISC, retrospective of 114 eyes, the majority of which were comprised of intractable CME, ERM, or retinal detachment requiring vitrectomy. Again, good visual acuity outcomes were seen with improvements by 3 months, and good anatomic results were seen. For macular hole, Muselier, in a review of 120 eyes, compared phacovitrectomy to vitrectomy. Both groups underwent ILM peel, and again, good hole closures were seen, and good visual acuity outcomes were obtained at 12 months. However, visual acuity at 6 months was improved only for the combined group, but not for the consecutive group. So lastly, let's look at the projected refractive error compared to the actual outcomes. And we see that in these series for very different diseases undergoing phacovitrectomy versus sequential surgery, that the difference was relatively small and was on average less than 1/2 diopter in the myopic direction. So I hope I've convinced you now that phacovitrectomy is a reasonable procedure with good outcomes for a variety of vitreoretinal diseases. It treats both the diabetic or the retinal condition and obviates the need for a second procedure. Visual outcomes are good, complication rates are equivalent to sequential surgery, and there's a faster time to best corrected visual acuity improvement and stabilization of vision for a variety of diseases. Thanks for your attention.
Thank you, Dr. Lim.